I welcome you all for the 8th Creative Theory Colloquium 2021. The title for this year's colloquium was COVID-19 Pandemic, Grassroots Experiences and Democratic Responses. The colloquium was organized by Foundation for Creative Social Research.
A very good evening to everyone, and let me welcome you all to the last session of 8th edition of Creative Theory Colloquium 2021. The topic for this last session is a very important one, and it is the COVID crisis and women's mental health issues. The chair for this session is Lauren Langman, Professor, University of Chicago. We have three speakers for this session. The first speaker will be Aparna Joshi, who is currently working as an assistant professor with the School of Human Ecology at the Tata Institute of Social Sciences. The second speaker is Cicilia Chettiar, heads the Department of Psychology at Maniben Nanavati Women's College, where she has been for the past 17 years. And our last speaker will be Subhada Maitra, Professor, Mumbai Campus, Center for Health and Mental Health School of Social Work, Mumbai Campus. The discussant for the session will be Savita Singh, political theorist and a feminist poet from Delhi. She did her MA and MPhil from Delhi University and went to McGill University for her PhD. The rapporteur for this session will be Sanjana. Aparna Joshi.
So, first of all, thanks a lot for the introduction and for the invitation. And really looking forward to this dialogue on such a vital but often neglected issue of mental health. So, let me first talk about what is the position from which I plan to, share my thoughts today. So, there are three positions, three hats that I'm wearing to make sure that I convey COVID-19 crisis and women's mental health connection. The first hat I wear is an academician because I teach at the Tata Institute of Social Sciences. The second one, I'm an interventionist. I run a national level helpline called iCall, which provides free but professional services which are multilingual to the whole country. And we have been providing these services for past 9 years. And during COVID, apart from our regular helpline, we also ran 3 specialized helplines to address COVID-specific issues, to address issues of vulnerable groups, and also to address issues of healthcare professionals and mental health care professionals. So that's the second sort of experiential lens from which I'll be talking today. And the third one is I identify as a cis woman. So clearly my own journey also informs what I'm going to share today, right? So I was just thinking of dividing what I'm planning to talk into 2 or 3 broad chunks. The first one is why is it important to adopt a gendered lens of looking at mental health? The second thing I wanted to talk about is what was the impact of COVID-19 through these 3 sort of experiential lenses I had that I got to see in terms of how it affected women's mental health and how it affected women's help seeking also. And lastly, it's not okay to talk just about problems without suggesting what's the way forward. So that's what I plan to do in today's talk. So the first thing to start with why gender considerations are important when you talk about mental health. To begin with, gender is a very, very critical determinant of mental health. Gender itself, I'm not conceptualizing necessarily in binary, but gender as a continuum. But even if you take as, it as a binary, data from across the world shows that gender affects mental health in 3 essential ways. The first one is the kind of stressors that men, women, or people of different genders that are likely to face are very, very unique and rooted in their life experiences as well as their socialization processes. And they're very different for men, women, or people of other gender expression. The second way in which gender sort of determines mental health is the kind of manifestations of these stressors and the distress that people experience. So typically, if you see that, common mental disorders such as depression, anxiety, or stress, or obsessive compulsive disorders, or for that matter, physical manifestation of mental health distress are commonly found in women as compared to men. Sometimes almost double the number of women in a given community face these manifestations as compared to men. Whereas data for severe mental illnesses shows that it's almost the same for men and women. So that's a second way in which gender sort of determines mental health. And the third way in which gender determines mental health is the kind of help seeking that is available to men and women, access to services, access to support systems, but also consequences of mental health. So a diagnosis of mental illness for a man and a woman have very, very different consequences in a country like India. So when a man has a diagnosis of mental illness, given the gendered socialization, patriarchal arrangements, men are likely to be cared for more despite their diagnosis of mental illness because the caregivers are often women. Whereas data from India and other countries also shows that if women are diagnosed with mental illness, then definitely the consequences are very different socially, legally. For example, a diagnosis of mental illness or unsoundness of mind in a country like India with 200 plus laws, governing social or political or economic rights can deprive women of these rights. Divorce, nullity of marriage, child custody, many other issues. Women also suffer the consequences in terms of desertion, divorce, and many other, perhaps negative consequences. So gender very clearly is a very, very critical determinant of mental health, even prior to COVID, right? Now, let's dial back and try to link the context to COVID. And my experience shows that gender was affecting people in two ways. One is definitely, I think, the pandemic, COVID, the physical threat of COVID. But what we experienced at iCall or through my sort of interface with my own clients also is as the physical threat impacted the whole society, I think it's the lockdown which created another set of mental health implications, and it's very important to keep that in mind. So keeping those three lenses that I talked about, unique stressors which are gendered, the kind of manifestations that are gendered, and help seeking and social consequences are also gendered, everything you got to see during COVID. So the first one is women's, the kind of, while at one level we talk about COVID as an equalizer, for the first time, it was not an issue of a smaller subsection of the society, but it impacted everybody. At the same time, while it was a levelizer, it was also a divider. It had a differing impact on differing sections of the society, and women being one of the vulnerable sections of society had different kind of unique stressors. Typically, you found that apart from the regular kind of stressors which are embedded in patriarchal structures of women's socialization, women had to definitely take due burdens and very, very extended burdens of care within the household, with schools being shut down, work from home. Working women had to face different kind of caregiving burdens without any due acknowledgements. Several calls came to iCall basically talking about this, lack of equitable division of labor and how women suffered as a result of that. Other things is women were lost their jobs, but were also doubly impacted by men's loss of job and economic dependence, and as a result of that, the kind of stresses that they had to experience at home. Definitely, I think as we talked about COVID as a pandemic, the country like India also reported domestic violence as a shadow pandemic. If you look at the initial figures by the National Women's Commission, they received double the number of cases or calls that they could have received during the first month of their helpline functioning. So many of these unique gendered stressors that women were reporting, and unfortunately, while their caregiving burdens or experiences of abuse and violence increase, I also want to say that while we focus on violence, we need to focus on violations also. So simple rights to rest, simple right to equitable division of labor, simple right to do things that they enjoy, simple right to care, simple right to equitable access to healthcare, Many of these rights were also unfortunately violated, and women called us with all of these stories. So there were unique stressors, but on the other hand, even access to help or support or health care or mental health care was also compromised during this time. Given the lockdown, the typical, sort of anyway, support systems are very, very minimal for women, but whatever support systems are available, unfortunately, could not be reached out. uh, Even the health system was occupied handling COVID related queries, so sexual and reproductive health services or other regular health services were also not available to women. The mental health infrastructure in India went through a shell shock. Anyway, there is a dearth of mental health services. All of us know that 150 million people in this country are in need of immediate mental health care services and are diagnosed with mental health. But at the same time, the kind of services that are available, we have less than 9,000 psychiatrists and even lesser number of other professionals. So the divide is huge. Even whatever services were available, unfortunately, could not be made available to women because they had to take some time to move from offline to online modality. And that made sure, that unfortunately made an impact on women's access to mental health care services also. So women had to deal with these unique stressors, and also definitely they had to worry about access to mental health care services or support systems or healthcare services. There were added burdens of increased substance abuse, especially amongst men, uh, or the lack of access to substances, and therefore its impact on women's mental health. There were several stressors that women were facing during the initial period. The second wave of COVID pandemic created another kind of an impact. While COVID and lockdown were the important themes, in the second pandemic wave, grief, loss, and any unfortunately no possibility of processing that loss, because the culturally available ways of processing grief were not accessible to many people. So those were the themes, but women called us, and safety was also a very important concern. When they were calling us from their limited access to telephone services and limited access to privacy, we had to be also mindful of the fact that whatever help we are providing should not cause further sort of, jeopardize their safety or well-being also. So we were working essentially amidst the, these kinds of resource poor backgrounds. Even the traditional services, see, mental health is not the only service which is catering to women's needs. There are domestic violence services, criminal justice system services, legal aid services, NGO services. Many of them were not functioning, and all of these issues are mental health issues as much as they are perhaps violence issues or rights based issues. And unfortunately, women were suffering. The second point I want to quickly make is women themselves are not a monolithic identity, right? A lot of times we club everybody as women, but within women also there are marginalized sort of groups. So there were women with disability who were calling us. There were women who identified as genderqueer or sexual queer were calling us because the pre-COVID support systems were not available. They were stranded with families who they were not out. And it was very difficult. There were pressures to get married. We had so many calls with suicide and self-harm also concerns, whereby women were saying it's better to end life. We also started a separate helpline for addressing the caregiving burdens of health and mental health professionals. Again, a lot of calls from women who were sort of navigating the family roles, caregiving roles within personal as well as professional domains without adequate support. Again, women with prior histories of mental illness was another vulnerable group that, suddenly earlier they had access to services, and almost for a month there was no access to services, to prescriptions. So this huge transition took a lot of time. I think I just want to now start talking about what is the way forward. Yeah, I think COVID pandemic brought the issue of mental health from shadowland to mainstream life. At least that's what it did. But at the same time, it also brought up some of the major limitations of mental health services in India. Mental health services, even prior to COVID, were struggling. There were several limitations. One of the first being the dearth of services, the second being the predominant discourse around mental health services in India being biomedical and diagnostic, often ignoring contextual realities, including gendered realities of people's lives. And therefore, what National Mental Health National Mental Health Program calls minimum care for mental health, maximum number of mental health, services, which often translates in biomedical services, collapsed because many of these did not require clinical solutions. They required perhaps, social solutions, psychosocial interventions. So I think it's very, very clear that COVID pandemic has created a need for adopting a psychosocial approach to viewing mental health issues rather than a diagnostic or a biomedical approach. It has also brought in a dire need to include mental health as an important component in the pandemic toolkit intervention and not as a vertical or add-on component, right? The third thing is, iCall ran several interventions with people who were working with women in any capacity, domestic violence, health services, SRH services, to make sure that if women were reaching out to these services, mental health or psychosocial services have to be an integral component of all of these services. So I want to suggest that mental health also needs to dialogue with other welfare or other rights-based services that are available to women and need not be treated as a separate standalone service. So iCall ran a 6-month training for all counselors across 5 states who were providing services in one-stop crisis centers, because now they realize along with domestic violence, they also had to address mental health issues. So I think it's very important that to use this as an opportunity to now integrate mental health and mental health services, not only to provide services which are symptom relieving or distress alleviating, but which also affect or work with the determinants of mental health, which are embedded in poverty, gendered structures, patriarchy, violence. So again, as I said, that I think it calls for intersectoral linkages, it calls for gender sensitive linkages, it calls for a rights-based approach, it calls for community-based interventions, because no matter how many specialists you create and train in a country like India, without community participation, none of these services are going to be of any use. So I think it's a time to build new kind of lenses, new kinds of structures. And the last thing I want to say, and with this I will end, is while you talk about healing, don't forget the healer, right? We talked about building capacities, we talked about providing services, we talked about new lenses, but we forgot the people who were delivering these services. And we realized that many of the people, mental health practitioners, community-based workers, even healthcare workers, were going through the same kind of trauma as their clients or as the women that they were working with. And it's very important that if you don't invest in the self-care of these healers or service providers, then you are definitely likely to run out of your own resources, because self is the primary instrument of change when it comes to provision of services. So with this, definitely I want to say that while COVID has impacted women's mental health and services also negatively, I think it's also a great opportunity to build new services with a new perspective. Once again, thank you so much for giving me this opportunity to share my thoughts, and looking forward to the next session. Thank you so much.
Yes, the next speaker is Cecilia Chettiar.
Good evening, everyone. Thank you. And firstly, Aparna, congratulations on iCall. I must say, a lot of my iCall was referred by me to a lot of people because your services came in immensely of help. Some of my students also needed to use it. Colleges being closed, they didn't have access to the college counselor, and iCall was the first number I used to give, and they got wonderful
Thank you so much.
responses.
Thank you so
And you have presented such a wonderful and elaborate summary. You've made my job very, very simple. So I thought I will talk to you about 3 programs which have found tremendous success during COVID. So the first one I'd like to talk about, I'm just going to refer to some of my notes here. The Center for Mental Health Law and Policy, based in Pune. Now they have come up with this program called Atmiyata, which was not COVID specific. This was a mental health perspective support program. It was a community based intervention program meant specifically for the rural areas. Now, they work with two tiers of community volunteers for identification and support for people in distress. They're working with common mental diseases like depression and anxiety, and they provide evidence based improvements in 4 to 6 mental health support sessions. They also try to raise community awareness on social issues. I can share the link. They have these beautiful films called the Atmiyata series, which are freely available on YouTube, which deal with issues like alcohol abuse, domestic violence, unemployment, psychophysiological symptoms. These films are in Marathi and in Gujarati. The third process by which they work on this program is they make referrals of persons with severe mental disorders to mental health services offered within the public health system as and when required, and allows individuals to access social benefits. Now, during COVID-19, Atmiyata's training sessions were adapted and offered to volunteers of various organizations. The model was very simple. We already have our ASHA workers, we already have our SHGs. Not they were not as easily or as extensively available during the pandemic in the villages, but through the networks that were already established, they were able to reach out to the general public. The problems were primarily basic. There was no food, and then you talk about mental health, the survival became the primary issue. But how can I use this difficult time to build up wellness, or to build up even survival skills in the community? They Because the program has already been running, there's a Mariwala Health Initiative, there's the Canadian Trust government which is funding it. So there's a lot of funding for this program which has already been there. So they have 3 levels. They have your mitras, the friends who will identify people who seem to have some trouble and start talking to them. Then they have the champions, Atmiyata champions, who are a little more skilled when it comes to counseling and supporting them. And then it came down to the local community also, where they just kept referring people to each other. So someone's constantly having a headache, someone's constantly having back pain, and medicines are not helping. What does this person do? That's when the Atmiyata Mitra or the champion steps in and said, maybe the headache, maybe the backache is not a physical problem. Let's talk about it. Let's see what's bothering you. This program Atmiyata was nominated for the SKOCH award in 2019. Now, in 2019, they had 14,000 people screened. 1,350 people with mental health issues were helped, and they were helped with 1,350 people were also helped with social benefits. Now, important for us, empirical evidence, the GHQ, which is a general health questionnaire, they found a reduction from 63.8% to 36.3%. The scores dropped from 6 plus to by around more than 9%. So there's an 80%, almost an 80% improved well-being outcome after the intervention. So Atmiyata program is one of these examples of how we can bring about changes in the community using the skills. Now, the other challenge for a country like ours, we believe to be a mental health worker, you need to do a bachelor's in psychology, a master's in psychology, do your MPhil, and you need to have these certain number of years of training. But in a crisis like the COVID pandemic, we don't have enough resources. We upskill our existing resources, and the strategies are not very complicated. Sometimes it's as simple as active listening. You need someone to listen to them. You need someone to just tell them, we are here with you. They're not interested in solutions. Like, for instance, when we recently had the floods in Mahad, we had a team which went from Prafulta, only all Marathi speaking volunteers. Now, as it is, this village was suffering because of the lack of employment. This was a very small village that they approached. The total number of villages were about 150. After the floods and everything being washed down, there were only 43 survivors. These 43 survivors were just people who had stepped out for some work. And when they came back, they had no village to come back to. It had gone a few kilometers down. They were not even willing to go down and find the limbs, and those were very emotional moments. There is no solution here. You need skills of listening, empathizing, just saying that I'm here for you, helping them to get into a routine again, making sure that they are able to wake up in the morning and eat. I may not need a master's in psychology to be able to convey this. I can use my existing healthcare workers to continue services like this. They found tremendous success. And I think the best part about that program was when the volunteers were coming back, they said that please don't go, or if you have to go, come back again. And they said, we are feeling like we matter. Because for there was a lot of support in terms of food coming or clothes coming. Material support was plentiful, there was no shortage of that. But out of the 150, there are just 43 people left. They have to rebuild the village again, establish connections again. And the trauma is so intense that you're not going to be able to deal with it just by going to sleep on time and eating food on time. So they don't want the raincoats, they don't want the pillows and the blankets. They want to know, why should I wake up tomorrow morning? Just the fact that, oh, you're coming to talk to me, I have to speak to you, I will wake up tomorrow morning. That one reason was enough for them to give this get strength. What initially started off as a program to provide medicines for the elderly. Now I'm talking about Project Bombay, Project Mumbai. This is helmed by I think Shishir Joshi. Now again, this is a project which has been going on for a while. They have been doing all kinds of development projects around the city and extending even into the rural areas. Initially, the plan was just provide medicines and food for the elderly, but within a year, they realized the demands were so intense that they had to set up another helpline, toll free helpline. Here again, they have this entire system of training the volunteers. They make sure that the volunteers are qualified. um, Having someone to speak to when you know that you don't want to get up or move is so crucial. And that one number, things like iCall, things like Samvad, helplines like Samvad, which is being run by Project Mumbai, these are the programs which provide them help. Now, Aparna has already spoken about the challenges that women faced, so I'm not going to emphasize more on that. Yes, we all know what are there's domestic violence, there's blaming of women for everything that goes wrong on this planet, in the house. Blame the woman for it, and that's kind of a given. But I want to add, as a therapist, I found another change that, I mean, I guess it's not a change, it has always been there, but I feel we need to speak about this. Yes, women are struggling. In the therapy, or the people who came in for therapy, I found a lot of challenges with the men, because something that we do not do culturally, socially, academically, is we don't talk about emotions. And when you're talking about mental health, essentially what are you saying? We are saying someone who has a emotionally regulated system, someone who's not extreme in their emotional reactions. This is something which is not part of any academic setup, whether it is an urban setup, whether it is a rural setup. If we teach our kids and ourselves, when there is a happy occasion, how do I deal with it, and when there is an unhappy occasion, if I deal with it, that's the starting of your mental health care, your self care. But we have not talked about this forever. And when we do talk about it, we talk about it with women, okay, because they are the more emotional gender, they are the ones who are hormonal, and they are the ones who will react rather than respond. And with a lot of marriages that have been breaking up during COVID, and a lot of couples therapy that we were seeing, I realized that men are not saying that they are not emotional. Men are not saying that they are not going to show their emotions. We need to create a channel for them and create a space for them. They were able to. It was very impressive for me as a therapist. I've been providing therapy for the past 20 years, and it's always been, when it comes to couples therapy, it's all about how the man is handling things a certain way and the woman needs support. And there was a change. The change was a man needs support here, and the woman is handling things differently. So the emotional awakening that has happened during COVID, with people realizing that we are staring at each other's faces 24 by 7 and there is no escape. I can't run away to work. I have to deal with my baggage before I blame you for your baggage. It was very, very heartening to see so many men also step up to this and say that, yes, okay, emotionally, I'm a mess. and I can use the word emotion and me together in the same sentence. So that was extremely heartening. Okay, I have another 4 minutes. Okay, as Aparna said, we need to have some kind of outcome of for all of this. We'll just be discussing problems. There are organizations which have made an impact. Project Mumbai Prafulta and the Atmiyata series, these are just three programs that I have picked up. iCall is one. I would definitely like to say if iCall wasn't there, I don't know what a number of my students would have done. As teachers, we can reach out up to a point. In the educational system, even since I'm from SNDT University, a women's university, I have more access to women. And it was so sad that parents were telling us that वैसे भी this COVID is going to go on for another 2-3 years. We were going to give her only that much time anyway to finish studies, then we were going to get her married. So let's get her married now. And logistics, because if we get married now, there won't be too many expenses. Let's forget the marriage done and forget it. Let's not bring her back to the classroom. For us as teachers to hold on to the student and say, just give us this time with her for online classes, just give us this space with her so that we don't lose her, because then the student just drops out of the system. Then she's become another statistic in the number of married people or the number of dropouts. And there is a generational change that comes about with an educated woman, which we all know. And that was something we were afraid of losing because of this lack of support. So if for me, if I want to tie all these different elements together, what I understood over the past more than a year is people react with fear. They don't recognize that the anger that they're showing is not anger, but it's fear or it's sadness. If I or other mental health professionals can help them acknowledge that, listen, your reactions are based more in fear and sadness, and let's deal with this, then the person who's in trouble does not have to lash out in anger. This lashing out in anger is what we're seeing as domestic violence. When I'm saying that the husband is unemployed and so he's beating up the wife, because a number of cases he's feeling inadequate. And I know we want to support the woman, and yes, we do. But what about supporting the man to access his emotions and say, listen, why exactly are you hitting her? Is it because you're afraid that she's going to judge you? Is it because you think कि मैं अब नामर्द हूँ, मैं कमा के नहीं लाता हूँ? Is that because I'm not bringing in the bread, so my wife doesn't respect me? But if we can show that to you, that listen, acknowledge your fear. Let's work on the fear. Acknowledge the sadness that you feel because you may have lost a best friend during COVID and you don't know how else to take it out, because men shouldn't be talking about emotions. But if we talk about it, you can go back home and not have to beat up your wife to find relief there. Or you may not have to withdraw privileges of your children or stop your kids' education saying that, oh, okay, I cannot afford to pay them. So speaking more as a mental health professional, one thing that has become glaringly obvious is the need for emotional education, emotional regulation. And this is not just in the cities. In fact, we found that a lot of these projects, because I'm personally connected to a lot of people here, the stigma is more in the cities for mental health than it is in the rural areas. These people in the villages were so happy that their thoughts, their emotions and feelings mattered. They said that just talk to us again. We are happy that you're talking to us again. Some of these projects are giving smartphones to the Atmiyata champions or the self-help group workers or the advocates and using them in contact. So we do have options of spreading community-based mental health interventions successfully in rural areas too. The stigmas are things that seem to be bothering the urban centers more than the rural centers. And the reason counseling increased so much during COVID-19 is because now you don't have to walk into a therapist's office. You can, do online sessions and nobody knows whom you're talking to. So you escape the stigma and people are willing to open up. And yeah, I guess that takes up my 15 minutes. Thank you very much for your time. Thank you for having me on board. I move on to the next. Thank you.
Okay, thank you. Our next and last speaker is Subhada Maitra. And again, I'm sorry with my accent if I'm mispronouncing your name.
Thank you, Professor Lauren, and a very good morning to you. And you said my name perfectly well, so please do not apologize. It is Subhada Maitra. And good evening and to everyone here, and thanks to the organizing team for giving me this opportunity to share some of our work and my thoughts around the pandemic and women with mental health issues. Uh, I have divided my presentation, my sharing, in three broad parts. The first is setting the context, and in that, I'm going to talk briefly, I hope, about a project that I'm handling at Tata Institute of Social Sciences. This is called the Tarasha, and I will raise issues around the pandemic. The second part is going to be the experiences around the field, Tarasha's experiences, and the last one is emerging issues. So let me introduce Tarasha. Tarasha was set up in 2011 as a community-based recovery and reintegration project to respond to women's unmet mental health needs. We primarily worked with women. We started our work with women and exclusively with women, and therefore I feel happy to talk about this project here. We worked exclusively with women in the mental hospital, regional mental hospital, Thane. These were the women who were abandoned by their families, who had no skills of living outside the hospital, and they were currently asymptomatic. They were not having uh, any major symptoms of the illness. So they were, in a manner of speaking, ready for discharge. But in 2011, the state had assumed guardianship and refused to discharge the women. However, the Directorate of Health Services, the Director of Mental Health Services, was a very progressive woman. I would love to name her, Dr. Archana Patil. And when I first went and talked to her about the concept of the project, to say why we need to discharge women and why no one can take guardianship of the women because they are adult women currently asymptomatic. So we were really doing the UNCRPD on the ground in terms of legal capacity. Uh, so we were getting women discharged. The three cornerstones of Tarasha are safe shelters because women were abandoned and they had nowhere to go. Livelihoods because they needed something to for a sustainable living, and I believe then, as I believe now, that achar making, papad making, bunai, kadai, stitching petticoats and blouses doesn't earn anyone a livelihood. So livelihoods was another cornerstone, and a third one was self-care issues. We believed also in not creating or building structures because we think and we know that there are enough and more community-based organizations whom we could partner with. So we believed in partnerships and collaborations, and we had working women's hostels, daycare centers, and vocational training institutes as our on-the-ground partners. So once the women were discharged, before they were discharged, we did very intensive work with the women in the hospital through group and individual sessions, got them ready for discharge. These sessions addressed issues ranging from understanding mental illness and their symptoms, being aware of how their mental symptoms develop or get aggravated, demystifying mental illness, to talking about self-care and hygiene and how important it is, to focusing on emotions and getting in touch with emotions, but also to express anger, because all along women are told, don't be angry, don't scream and shout, don't abuse, it doesn't suit you as a woman. And we said, well, anger is one of the first steps to change. And if you are not angry about your situation, you will not be. So we discussed a range of issues, including sex and sexuality, because these were single women going out into the community, living on their own. And it was inevitable that they will form relationships with men, not all of which will end up in happy endings. So we did work with the women in groups and individuals in the hospital for about 6 to 8 months, got the women ready for discharge. Once again, for the first time in the history of mental health, adult women, asymptomatic, lodged in mental hospitals without family support, were able to get discharged through the visitors committee and not go on leave of absence or parole. So that was the first for our project, and for the mental health sector, I would say, which was a great, and thanks to Dr. Archana Patel at the DHS. Once the women were discharged, we put them in working women's hostels. These were mainstream spaces where you and I would go and live if we didn't have a shelter on our heads and we wanted to work in a strange city that is not a home. They started going to a daycare center and then vocational training center, and finally found jobs in mainstream occupations. So as soon as they got out of the hospital, what happens? You need to become familiar with the city. And I call it occupy your city, own your city, love your city. And how do you do that? So we taught, we not taught, we took women on tours around the city. So some women wanted to see Shah Rukh Khan and Salman Khan's homes. Some women wanted to go to the Chowpatty and eat street food there. Negotiating public transport, finding out recreation spots, gardens, parks, theaters, going and eating in restaurants, all of that. So becoming familiar with the city, and then daycare center, vocational training, and finally a job. So daycare center and vocational training took about 3 months each. Once they got the jobs, within 8 to 10 months of the discharge from the hospital, the women were on their own. So the first 6 months when they were with Tarasha in hostels and daycare and vocational training, we were taking care of every need of the women. When they came out of the hospital, they were undocumented persons. They didn't have anything. They didn't have their clothes, underclothes, chappals, bags, no basics. So when they got discharged, we would provide them everything from, your individual thali, katori, chamach, glass, because we wanted women to also understand dignity, and we wanted to do that dignity in action. Once they were independent, after having gotten jobs, our condition in 2011 was that women get a job for minimum 6,500 rupees, because that is what is needed, basic minimum to survive in a city like Bombay. If you were to live in a hostel, pay for your lodging and boarding and travel, and a little bit of extra expense for your daily needs, sabun, tail, powder, sanitary pads, all of that. So once they became independent, we stopped supporting them. And today our women have not only maintained recovery and been reintegrated in mainstream society, but they have also been able to stand on their own and creating multiple identities beyond that of a mentally ill woman or a mad woman. Exit is one of the key phases of our project. So while we continue to support women, offer psychosocial support, we also get them to exit the project, because we don't want to be Maibab. We don't want them to tie to us. We are a project. We don't want them to tie to us forever, but they can always access support, but they must also exit. So when the woman is ready, many of our women have exited the project, but still continue to be in touch. More recently, just before the COVID pandemic, I must mention that women have worked in mainstream occupations like retail and sales, hospitality, housekeeping, printing technology, more recently home-based care, and such other. And today our women start with a minimum salary of 10,000. Imagine less than a year after coming out of the hospital, a woman who has been within the hospital for 8 years, 5 years, 10 years is on her own and living in the community. Two other programs that I want to talk to you about briefly, and these programs have again evolved organically from our recovery and reintegration program. The one is mental health at the workspaces, and this is because our women occupy mainstream workspaces. Now, this is an opportunity that we saw to sensitize other workers in organizations around mental health issues. So mental health at the workplace and caregiver support programs are our two other programs, and mental health at the workspace, we go into the organizations, corporate organizations, and talk about mental health issues, and we do a lot of activities with them. As of now, we have trained, we have sensitized 900 corporate employees and employers around mental health issues. Caregiver support program is giving support to caregiving families of persons with mental illness. So let me move on. And if we have questions, then I will address those questions around these programs. We are all familiar with the way the health system collapsed and could not adequately deal with the raging pandemic and its fallout, let alone handle and respond to the mundane health concerns. While those living with mental illness were invisibilized, in a manner of speaking, mental health suddenly came to the forefront, and not at all surprising given the curbs around lockdown and social distancing. In fact, mental health issues, and Aparna and Cecilia both have referred to as being one of the three shadow pandemics: poverty, domestic violence, and mental health. How are these linked? What does the data around these three issues tell us? Over the last 2 days, we have heard about, and I don't want to say it because I'm running short of time, but my question is all this that we've been discussing gendered? Are women, persons with disabilities, those belonging to non-normative sexualities more affected than others? And we have heard of feminization of poverty, know the hard facts around domestic violence and about women's lived experiences contributing to their poor mental health. These issues were always around, but got only magnified during the COVID pandemic. And now I move to our experiences from the ground. So within the hospital, with the lockdown, everything was shut. Even the few families that came to visit the patients did not have that access. Families were not allowed inside the hospital. They were completely locked in their own wards, and that was a major stressor, with no activities, no occupational therapy, no daily routine, hardly conducive for well-being. Outside the hospital are the Russia women. I wanted to tell you stories, but I can't. But many of them lost their jobs or gave up their jobs voluntarily. They had a lot of fear and anxiety about their future. And lots of times they lost their jobs because of their inability to travel, do psychiatric consultations, and keep up with their medication. And 24/7 isolation. Some of them were on 24/7 call, house helps, childcare assistance, and with no networks. This was a major stressor, and women were moving towards relapse. At the workspace, the organization culture changed. So while there was one positive fallout of this whole thing was there was attention to mental health issues within the organization, and they wanted to be supportive to their employees. But on the other hand, work from home resulted in diffusion of boundaries, particularly for women, the added burden. And many of the things that we already know. Similarly, the caregiver support program, all our primary caregivers were between 35 and 65 years of age. Not an easy age to look after a person with mental illness. Most were homemakers, some were engaged in wage earning activities, including domestic help and outreach workers and such other. The diagnosis of care recipients was severe mental illness, and they again faced among many other things that we've already discussed, but irritability with the care recipient. So they were short, they were experiencing burnout. So they had their own mental health issues to deal with, in addition to issues of loss of livelihood and ration and supplies, including medical facilities. My last few minutes, I'm going to talk about emerging mental health issues that need attention. We are talking about a digital India and a digital divide. How does it affect women? In a state-run mental hospital, in 1.5 years, we are into the pandemic, and the state was not able to organize internet facilities so that we could conduct online sessions for these women in the hospitals. What happens? They just remain locked out. access to integrated community-based mental health services, including psychiatric consultations, access to medication, etc., etc. And how do we view women with mental health issues, particularly during the pandemic? We need to change, I think, our paradigm, our lens of understanding these issues. So from pathology to move women to normalization, no, it's not about normalizing, but understand the process of recovery, which is back and forth, which is non-linear. Understand the uniqueness of the individual. Don't protect women. You know we have agency and they need to exercise that agency. From changing the person, we need to move towards how do we change the environment and the detrimental environmental conditions so that women stay well and their well-being is realized. Include them in your programs not as survivors or recipients of or beneficiaries, but as participants. Ask them what they want. Check out. And finally, understand that they have the freedom to be, to choose, to live. Thank you so much.
Okay, thank thank you. And finally, our discussant is Savita Singh. Let me say this. I'm a sociologist, but I began my career as a psychologist. And so I found these the presentations extremely interesting in terms of the similarities of mental health issues and the cultural differences as well. And just for what it's worth, my wife is a psychiatric epidemiologist. So, Savita.
Thank you so much, Professor Langman. And, before you joined and before others, 4 of us had joined. Subhada, Cicilia, and Aparna, and we were talking about how this whole thing is going to pan out. And they were apprehensive as to how ultimately it is going to sort of, result in what kind of situation. I must say as a discussant, first of all, that I was listening to each one of you with great concentration. One of the demands that was made by, I think, Cecilia, that we need to listen. Most of us, we think that we are mentally stable. All of us have our own zones of darkness. It is a matter of time when we can lapse into something what we call abnormal or mentally unstable situation. All of us. Nobody, I think it is the stress that the system generates, the capitalist system within which we live. It keeps people all the time stressed. The way, for example, if it tells you, if it propagates certain kinds of standards of life or goals of life, which you must attain to be able to lead a normal life, this itself is a very damaging thing. Marcuse, for example, calls it one-dimensionality of human life, which is a very good analysis, a very good description of how stressed we are, because as human beings, we have many dimensions which we should pursue. And Subhada's last part was so pleasing. In fact, all 3 of you, if I just discuss the presentations, it was all of your presentations ended at a very positive note. First of all, for this session, I was reading through many reports so that, I sort of come up to that level where I can at least understand what you people are saying, because what you do, I don't do. I've never involved myself in any kind of community service towards meeting mentally challenged people in one way or the other, depressed, whatever, in whatever sense we're talking about. And in each of the reports, I only found, the harshness of the condition, the level of domestic violence which was forcing women out of their own homes during the pandemic, disruption of services, mental health services, leading to greater stress than they ever faced. I think Aparna talked about other genders panicking, locked within the household as to what is going to happen to their lives because they were unable to meet their partners. In any case, socially, they are not allowed to they're not so comfortably allowed to associate. All kinds of panicking situations, paranoia, depressive conditions were built by pandemic. But here is the real analysis, as Aparna pointed out, that domestic violence is pre-existent. It has existed before the pandemic came. And it is already a shadow pandemic, a wonderful terminology. Because when the whole thing started in March in India, our School of Gender and Development Studies, we organized a webinar on sudden rise in domestic violence. Right at that time, Cecilia, we did not have reports, these kinds of reports that are available now. We did not have these kinds of authentic reports which were prepared on the basis of conducting empirical research. But at that time also I said that this domestic violence is going to tip women over to the mental imbalance that they had somehow managed to keep in balance. It was only a matter of slightly more increased level of aggression in the household was going to lead to this condition. So I would say a parallel pandemic of mental health issues with women particularly and genders of all sorts was an inevitable outcome of this lockdown. And then the second wave, eruption of deaths and real mortality, fatality, emotional emotional rupture of the kind that one had not witnessed before. One was staring a reality that was death very closely. So it would destabilize just about any normal person. But for people who had no hopes of feeling comforted by the person, suppose that person has lost somebody who was helping her, who was listening to her, who was a support to her. Imagine loss of that kind of person, what kind of situation would have created. So given the structure of patriarchy and capitalism within which we live, which is stressful for general people, for everybody. People want to get out of this patriarchal capitalistic structure because it is not only dehumanizing, alienating, it is actually destabilizing. But what is important and what comes out from your presentation, I would say I knew about iCall. You must know, Aparna should congratulate you. iCall is known in the feminist groups as a support system that women had. But Atmiya Center, Help Mumbai, Tarasha, these are not known to me and not known to many people. But look at the kind of work you have done. I love this literary name Tarasha. You know what Tarasha means? Tarasha means something that you chisel, you shape up. And Subhada was right. How her effort of community-based effort has actually reshaped these women. We should not say that they have been normalized. They have been rebuilt in a way. They have been reshaped in a way. Their mental life, their physical life, their social life. I'm sure she did not talk much about their sexual life. I'm sure they've been able to find partners. They've been able to form families, have children. All sorts of things that we call normal are happening with these abnormally situated people. So I think that pandemic has brought visibility to mental health issues, their nature, their perennial condition within which women exist, other genders exist, and the attempts by feminists like three of you and many others who have done extraordinary job. I did not move out of my house, during the lockdown. You people were working through all these community-based services that were, and you were responsible. So I should say that feminism and gender conscious people by their efforts, they have inbuilt capacity to not only respond emotionally to a situation, but also rationally. It's a rational response, I think, to an emotionally complex situation within which a lot of women find themselves. So, as far as the questions are concerned, people will be asking questions, but let me uh, just pose one or two questions of my own, which I will not ask later on. First of all, how how credible is your optimism? Second thing is that why do you think that other people will come around to join you? I am not so optimistic, all right? But I see I am infected by your optimism, and I must respond to you with a certain kind of doubt. I feel quite uh, unoptimistic, I should say, given the level of violence that rose because the domestic space also was occupied by men. And already the cases, if you look at the data of intimate violence in intimate relationship, it's pretty high all over the world. All over the world. If nothing is done to address this situation, why should I be optimistic? Who is going to change to come along with you on what basis? This is something that I would pose to you. It's difficult, but I love the optimism, but I doubt that it is enough. I think we work for liberation. We'll work for changing the system. We fight, we fight at a political level as well. My take on this. So with this, I hand it over to Professor Langman.
Well, I think we should begin by letting the panelists answer some some of the questions that Savita raised. I've often been called the last optimist standing in the room because I'm very optimistic about the long run. The short run, I don't know about. We may not even survive as a species much longer, but if we do, I am optimistic. And part and parcel of it, and this is not my type for a presentation, but part and parcel of it is the tremendous progress that women all over the world have been making. There are setbacks, as we now see in Taliban, but I am very optimistic. And so much of the progress that we've made has been due in a number of ways, in a variety of ways of women. So let me just ask if any of the panelists want to respond either to each other or to Savita.
Oh, maybe others can ask some questions. This was only to start.
Okay, so who has questions?
Before we start the question hour session, may we take the privilege of inviting Dr. Srinivasa Murthy. You must have seen that he has been posting in the chat box. He has been a psychiatrist and has worked on a lot of issues. He was in Nimhans, Bangalore, and he has worked on mental health very comprehensively. And very interestingly, Dr. Murthy has been attending all sessions of the colloquium from yesterday's morning. So, with the permission of the chair, can we invite Dr. Murthy to give a brief account of his works and also reflect on the issues that we have been discussing?
Sounds like a good idea.
So you have to unmute, Dr. Murthy.
No, I mean, thank you very much. It's been a very, very good learning experience listening to the things from yesterday morning onwards. Because of my own interest in community mental health, I found it very useful. Coming to the specific aspect of women and mental health, particularly in the pandemic area, we have a rich experience from the time of Bhopal disaster in this area. In point of fact, in Gujarat, we produced a specific manual on women and mental health for community health workers. I would be happy to share all of this, anyone who writes me to my email. The point which I want to make is that we should be recognizing that there are three levels of problems: distress, altered behavior, and mental disorders. Mental disorders form less than 10% of the total mental health needs of a population, men and women altogether. Secondly, domestic violence has been seen as a disaster. Not only now, we saw it in Orissa, alcohol abuse goes up, domestic abuse comes down because there is a lack of communication within the family. The most important thing that we need to do, if I can say it, which we are working upon right now, is develop self-care skills for everyone so that they use it in a day-to-day problem. Do you know that if, for example, even during this COVID, those who were doing exercise, who developed COVID, had less mortality than those who did not? Do you know just getting 8 hours of sleep increases your immunity? I can give you any number of things. I've written about it in the Hindu and other places. The point is that we must make it possible to reach every one of them. That's what we are working upon. Right now, I'm working with cancer survivors as well as caregivers of developmental disabilities to develop a self-care package, which is not only skills, but also to make sense of their altered, uncertain situation. There is a lot that needs to be done, lot that has occurred, and I'm glad that we are discussing all this. Thank you very much. You have my contact. I'll be very happy to be available. I do only volunteer work, and I'll be very happy to put you in touch with all the things, both my work and other work in the international sphere. Thank you very much.
Okay, thank you, sir. Yeah, over to the chair. Yeah.
Questions, comments?
Okay, I wouldn't mind going first if that's all right.
Fine.
Yes. So, Savita, how credible is my optimism? I will leave you to decide how credible it is. I will leave that to you. But will the others come around? I think our generation may have to struggle a little more. But the generations that are coming behind us, my optimism is more the long term optimism. I may not see an immediate change in my lifetime, but I am part of the machinery that has initiated the change which came well before me. But I'm part of the machinery that is still pushing for the change. Education, awareness, and something important that you raised, recognition of capitalistic dangers. The next generation is extremely aware of this. A simple example, which always gives me a lot of hope, the rise of cryptocurrency. Why is cryptocurrency such a big hit with the youngsters? It is a basic anti establishment move. We don't want government controlling our money. We don't want government seizing our bank accounts because even if I'm a legal citizen, the money is not always mine. The next generation is breaking, challenging existing norms, and they are creating space for effective discussions. The very fact that Aparna could start her talk saying, I'm a cisgender woman, how did that term even come? That term came because we are listening to it. We are listening to people. We're making it important for us to identify ourselves appropriately. We are part of the process which is allowing for more openness. The next generation, the people who are coming after us, I know we say a lot of things about how spoiled they are, how they are stuck in their phones, uh, but they are making decisions, they're thinking differently. Yes, they do come from privilege, but because of privilege, since their basic survival is not threatened, they are able to come up with bigger solutions. They are able to think about thriving, and they are able to look beyond self. They're challenging the norms for education, finance, health, and well-being. Retirement age is 60 for us. The next generation is saying, I want to retire at 40, 45. Why? They're saying, I don't want that money. I will go and open a farm. I will be fishing in one corner. They're saying, I don't want this capitalist crap that you're feeding me. I really don't want it. And I think one of the things we must do in a lot of these colloquiums, in a lot of these discussions, I find there's a lot of emphasis on things that have gone wrong. We need to also highlight success stories. So this particular year in my college, we have this research paper competition every year. So this year for COVID, we said instead of talking about what went wrong for COVID, we'll talk about only success stories. give someone a frame of reference. If you're only looking at what went wrong, how do I work towards how to build it right? Given it sounds very idealistic, but I don't think it is unreal. I don't think it's impossible. Let us not underestimate the next generation who's watching us. It's our job not to give them a standard and say, boss, this is what you can do and this is what happened. You come either ways. They are they have so many questions which are existential in nature, which probably even our generation had, but we did not work towards a solution which was established in the real world. Whereas these kids are a lot more capable in that sense. And artificial intelligence, yes, it comes with all its challenges and there are fears, but I am optimistic in the long run. As Professor Langman says, we don't even know where the species is going, and we may be possibly a few of us who are continuing to be optimistic. But if we show an opportunity for success, if there is a goal that we can drive towards, where you have youngsters now talking about consent openly, where it is no longer about I'm the handsome guy in class or all the women are going to fall for me. No, now the handsome guy in class is saying, oh, hello, I need to consider consent. We have started a narrative change, which is why I feel that yes, people will come around. Time will tell how credible this optimism is, I believe. That's it.
Yeah. Thank
Okay, thank you. And just for what it's worth, a very eminent German sociologist named Mannheim talked about generational change as the basis of change. And I think that feminism is just a beautiful example of this, because without asking personal questions, probably most of your mothers did not become professionals in any way, shape, or form. But many of you or your colleagues were activists 20, 30, 40 years ago. And if we look at all of the changes that have taken place, and one place where I have to say India is ahead of the United States without getting into the politics is having had a woman prime minister. Okay, other questions and comments? People should just speak up, because this system doesn't show me everybody who wants to speak. Savita,
just to respond to Professor Langman, my mother was a working mother outside the house, and my parents both taught me that you have to earn your bread, be financially, economically independent. And I think the seeds of feminism were sown very deeply through modeling in my family.
Good.
Actually, I raised that question to sort of expand the horizon where we actually are standing, because the mental issues in women, I think, is made invisible by patriarchy. There's a lot of shame and guilt is attached to it. Right? To bring it out in the open is like forcing the system to acknowledge women's contribution, women's labor of women's productivity or their contribution to national economy. You know that it is still very hard for this system to acknowledge, to accept at what level women work and what kind of life they lead in spite of doing so much. So it is this kind of existence which is very different from the existence that men lead in our patriarchy. All right. So from that perspective, I think it is so very difficult that I think that others, if they want to come and join us in this particular way of helping women or helping a situation within which we are locked, basically, we are unable to speak and we are unable to listen to each other. It is only I should say, perennial doubt that one has about one's condition, abnormal or normal. This is a kind of it's just a thin line between normal and abnormal. As Aparna pointed out, that we need to also take care of those who take care of others. You do not know when they are going to tip over to the other side. The level of emotional labor women have to contribute to keep the system going for the well-being of the entire family and society, the amount of emotional labor they invest in this rotten system.
So there is a hand raise by Mr. Thakur.
Right.
Yes, Andrew Thakur.
Yeah, thank you very much for wonderful presentations. I think this is something that we all are facing today. We were suffering. We had tremendous stress of our own, losing relatives, friends, being in the hospital. But at the same time, our students were suffering a lot. And I have collected the messages that they have sent to me, because I was one of them who listened to them carefully without talking much. So they kept writing to me that this is what is they're facing, and long letters they would write, even today, due to this online things. So I was always wondering that whether I'm a competent person to handle this kind of stress of the students or not. Thanks to you that you said that no, whatever resources we have to garner that, and we have to have the confidence to at least listen to them if you are not suggesting them anything good. So I don't have any guilt feeling that probably I did a wrong thing. But this is really growing. As you know, before pandemic also, we were already facing a lot of problems. I mean, in JNU medical shop, I just asked the medical shopkeeper that how much stress-related medicine do you sell? He said, if I start selling that without a prescription, I will not be having any other medicine. So much of that. And in All India Institute of Medical Sciences, a doctor who deals with mental health told me that what do you do to the students in JNU? 70% of the young people coming, they are coming from JNU. I mean, I'm sure he was joking. Maybe IIT has more than us. But what to do with these people, the younger generation? Because their stress is not only, I mean, COVID and online class have increased that. Their stress is not only related to patriarchy also, I guess. I mean, boys and girls, everybody had similar problems. So how do we do in normal times also? What do we do with that? Many of them tried, they are enlightened students. They didn't have any problem in suggesting that they have mental problem, some kind of stress-related mental problem. And they had no problem in going to the doctor. But most of them wrote back saying that there's a long queue there and doctors are very rude. And not only doctors, the staff is, so I can share a letter by a lady student of mine who has written a very emotional letter about how was it treated in the hospital. So what to do with that? How do we manage it? I mean, I don't know of any organization like Project Mumbai or Atmiyata Mitra in Delhi. Maybe now I will look for them. But normal professor who is not trained in that. And I'm sure everybody would agree that we also have our own lot of anxieties, professional anxieties, family anxieties and all that. So how do we deal with that? What to do?
Is it okay if I respond to this question? Yeah.
Please.
Yeah, thank you so much for sharing this experience of yours. First of all, I'm sure that your students are lucky, privileged to have somebody as empathetic as you to be present in their ecosystem, and you were there to listen to them and provide whatever support you could provide. So definitely, I think the session theme was women's mental health during COVID crisis, but one of the other vulnerable groups that was affected a lot during this pandemic was young people. And iCall received calls after calls from young adolescents, youth, young adults, talking about several, sort of uncertainties, the plans that they had made about life all went haywire, their relationships were breaking, several stranded with family. A lot of times they had never met those families for longer durations, and suddenly they were stranded within the same household. So I think it was very, very difficult for students of all genders, of different age groups, and particularly students who also, where their identities intersected with caste, class, or other marginalized identities also. So I just want to say again, data from India and other countries also show that many of the distress manifestations do not require clinical solutions. Right? A lot of times that ties up with Dr. Savita's question as to why that optimism, and I'll talk about that in a minute, but I just want to say that everybody right now during COVID was impacted in some or the other fashion, and that impact necessarily did not manifest as a psychiatric illness. It manifested as distress, which requires supportive interventions. And I think people like you or whoever was available, and iCall served as that, for example, one resource for people to talk about their distress in a confidential, anonymous, and non-judgmental manner also. People, a lot of times people have solutions. They require a space to unfold their own issues and hear them out. So I think one thing is such supportive spaces. And we realize iCall, for example, provides telephone services and email-based services. And many young people chose even further anonymity by saying, we don't want to talk, we want to write about our emotions. That's also something that this generation is far more familiar with. So I'm not surprised that they sent you messages, they sent you letters, because I think expression is far easier, anonymous, safer through those modalities. So I think definitely what are the kind of different support structures that we can create for young people, which are embedded in their everyday ecosystem. It could be they themselves for each other, it could be professors, it could be family members, it could be anybody else who is providing services as a helping professional. It could be a helpline like iCall. But I also want to take this opportunity to say that COVID will come and go. My optimism is also about, can we now take care of mental health issues as a very, very important issues and create preventive structures? For example, iCall works with IITs, iCall works with TISs, iCall works with many other educational institutions who call iCall once there is a suicide, not to prevent suicide, not to prevent distress, not to equip students with skill to take care or to create supportive spaces. I think that's also very important. My optimism comes from the fact that can COVID be used as an opportunity to highlight mental health as an essential service, as a needed service, and from a preventive aspect also. And the second optimism also lies that many of the mental health issues that people face in India, data shows, are not embedded in serotonin or their neurotransmitter or their brains, but in their everyday life situations. And they are linked very closely with the social determinants of their life, such as poverty, unemployment, or academic institutions, or relational conflicts. So while iCall, for example, worked in terms of taking care of that distress, iCall also worked in a very, very important way by helping people link to ground level services, ground level support structures, which help people take care or control of the determinants of their mental health. If we use symptom reduction approach, we will always be short of services. If we use a preventive whole society or a social determinant approach to mental health, we have a very, very long way. That means mental health or health systems will have to dialogue with other ministries, with other departments, with other stakeholders. Mental health is not just a mental health practitioner's issue. Mental health is everybody's issue. So therefore, my optimism, Dr. Savita also, I'm trying to answer both of these questions, that can we bring more and more stakeholders in mental health conversations and tell people that many mental health or distress issues require non-clinical solutions, which any one of us can provide here. And only for a handful of problems you require specialists. So I think hopefully we will take issue of students' mental health more seriously and not wait for another suicide to happen, but do something at a preventive level also.
There's a hand raised.
You wanted to comment?
Yeah, I'd just like to add to what Aparna is saying. Sir, if you can just create a safe, non-threatening, non-judgmental space for your students to open up at. That's all you need to provide as a professor. My students, I saw a large increase in the number of students who are willing to come up with an alternative orientation, and that was interfering with their ability to study or even to engage with others. So we allowed the students to create a queer space. They started a student-led initiative called Satrangi Hakse, organized by the students, designed by the students, run completely by the students, where they have gender, sexuality, orientation discussions with no faculty involved. So it was just, you hear this, the solution will come for you from the students itself. Just wanted to add that.
There was a hand raised.
I didn't see it. Whose was it? Whose hand was raised? My system doesn't show.
In the meantime, may I just ask a small question again?
Please.
In your experience, did you, during the pandemic, did you attend any case where gender violence was, domestic violence was diminished, which was stressing out that particular person or woman?
By diminished, can you just explain?
Diminished domestic violence because the mental issues erupted or sort of aggressively erupted because of gender violence as well, the domestic violence.
So I think there is a huge connection between gender-based violence and mental health, and it's a bidirectional sort of data shows that women who face domestic violence have a lot of mental health complications, and data also shows that women who are diagnosed with mental illness or are suspected to have mental illness, that becomes a ground for further violence. And we saw that cycle during COVID also. How can I escape during COVID? And especially given the fact that women with mental illness or women who were facing domestic violence not only had to continue to face those, but now were stranded within the four walls of home, did not have access to their usual support systems, they could not go out, they could not contact women's organizations, or they could not go to their psychiatrists or mental health practitioners or support groups. I think it did aggravate, and we received a lot of calls from these women, and that's why I said that also we have to remember that in a country like India, even though tele-density is very, very high, the access to telephone is household access and not necessarily an individual access, right? So it's very important that these women used to call us during times when they got relatively smaller privacy, when somebody was not looking or whatever it is. So I think it was very difficult to respond also to these calls, which otherwise during the pre-COVID period, we had access to many other support systems, which was unfortunately lost during COVID. So it was pretty challenging. And to answer your questions, yes, we received many such calls.
No, did you address it? I mean, did that thing got resolved in some way or the other?
See, domestic violence and mental health issues are not issues that get completely sort of resolved or addressed. But as you rightly said, the kind of support, are you asking what kind of support were we able to provide?
Yes, exactly.
So I think the most important support that we could provide during those times was, one is providing a space within that constricted existence for women to talk, right? Number two, I think safety planning also, because many of the women were living in unsafe environment without having access to external support systems. So how do women increase their external safety, interpersonal safety, and even emotional safety, given suicide, self-harm kind of thoughts? I think we had to work on that. And in extreme cases, we had to help women get out of the home, find shelters, link them to perhaps, police or other women's NGOs. I think it was very, very tough. Another thing we had to do, Dr. Savita, was also help women resist within even those limited resources. So for example, how can they snatch 10 minutes of their everyday life to engage in simple activities? We used to tell women that if you go into the bathroom during COVID, if you take bath for 10 minutes, spend 20 minutes there, because that's their time. Carry your mobile phones, listen to music, dance a little bit inside the bathroom. We had to be very, very creative, or cook something of your liking and just eat that. Because again, as I said, they couldn't go out, they couldn't meet their friends, they couldn't go to their natal families to gather support. So it was difficult, but through these smaller tools, we had to sort of, encourage women's resistance and help them maintain sometimes their sanity, sometimes question, sometimes keep themselves safe, all of that for that matter.
I think we have time for just one last question. Subhada had her hand up.
Subhada.
No, I wanted to make a comment when this question, Savita, you asked about domestic violence reducing. In fact, one of our women who was a long-term patient in the hospital and who was maintaining her recovery very well outside the hospital after discharge for like 6-7 years, she was estranged from her husband for several reasons. Domestic violence was one of those. And when she was admitted in the hospital, the family didn't want her back. But she was working as a home care assistant to an elderly lady, and that lady died. And it really hit this woman very hard because she was looking after the lady for almost 8-9 months. And then she decided to give up her job. When the family came to know that she was back in the hostel and, on her own, they asked her, they reached out to us and they reached out through us. They asked her whether she would like to come back. And she's back, and now the family is also negotiating in a way that some properties, some things can be actually transferred to her name. So now all of this, how does it happen? It doesn't just happen out of the blue that the family has become good and things like that, but it happens from the woman being able to claim her space. And if we have done all this work with her, which is, through a feminist lens, firmly believing in the empowerment of the woman, now we don't have to do anything with her or for her. She goes and negotiates. She says, I'm okay to live here, but I need some things that I can claim as my own. So they are in discussion with that. Maybe we will be called to do one final discussion. But yeah, I mean, many of these things women are able to reclaim, I think.
Well, at this point, we're now up. Our time is up. I want to thank all the participants. This was really, for myself, as on the other side of the world, this was extremely informative, especially for myself in terms of my own particular interests that join the questions of society and personality and mental health. As I said before, I actually got my start as a psychologist. I even went through 4 years of psychoanalytic training. But I figured that psychology was not the way to change the world. Sociology was. It took me a long time to realize that sociology wasn't going to change the world. But to kind of reiterate just what I said before as a token of appreciation, I really think that the history of the world has been a history in which men have controlled everything, and look what we've gotten. Part of my optimism is the extremely positive things I see about feminism, not just in the United States and India, but throughout the world. And I think that it's a wonderful note to conclude on, that the hope of the world is really in the hands of women, because men have just screwed it up so badly, running all kinds of despotic systems here, there, and everywhere. So I'd like to thank everybody and wish everybody quite well, and thank you all. Goodbye.
Thank you and bye.
Thank you so much
Thank
for
you for
inviting
having
us
us
and
here.
for a lovely conversation that was initiated. Thank you, Dr. Savita, for your attentive and excellent sort of, discussion role also. Thank you so much. And thanks to Professor Langman also for your excellent sharing. Thanks. Wonderful opportunity.
My takeaway is your optimism. I loved it. I raised it also because a lot of people don't think that you can help. But see how many women and children and other people you have helped. It's very important to learn these stories.
Yeah. Thank you.
Sakshi, you have to give Manoranjan. Yeah.
Thank you for watching the video. Do like and share our video. For more seminars and talk, please subscribe to our channel. If you have any questions, comment on the video and don't forget to press the bell icon for future updates.